before I get into some of the detail, I'd like to reiterate how hard the ABDO team is working internally and externally with all stakeholders, optometric advisors from the governments, representative bodies, the OFNC, etc., to support members during this unprecedented time. And I'd like everybody to be mindful that the situation can evolve and change quickly, and that all information that I provide tonight is current and relevant as of today and probably for the coming weeks. And yeah, without further ado, I shall start the presentation, which hopefully will work. So the first learning objective is to develop an understanding of patient questioning to elicit information in relation to coronavirus symptoms and situation. And within this section, we're going to talk about the coronavirus, the public health advice, the provision of eye care services just now, which throughout the UK is essential and urgent or emergency eye care, depending on the terminology used in each area. And sorry, the webcam closed by organiser. All right, I didn't put my camera off. So, sorry about that, and PPE. So, first of all, the NHS Public Health Department with description on the coronavirus is an infectious disease caused by acute respiratory syndrome. The main symptoms of COVID is a high temperature, a new continuous cough 3 times or more within the hour, or more coughing episodes within a day, and the loss or change to sense of smell or taste. The third one has just recently been added to the list. So with regards to most people that have the coronavirus, they have at least one of those symptoms. The guidance and from public health is that individuals with those symptoms should self-isolate for 7 days. If the person is within a household, lives within a household with others, and they have no symptoms, they should self-isolate for 14 days from when the first person in the home started to present symptoms. The 2-metre social distancing rule. So everyone knows when you're out doing your shopping, or if you're within the workplace, if you're a key worker, that you should be adhering to the 2-metre social distancing rule, and that goes within that remains for optical practices, and some of the practices who are providing essential, urgent or emergency eye care have already made the adaptations to their practices using floor tape, etc., to lay out the two meters, and also adapt practices seating to allow for patients to sit in the practice, adhering to that 2-metre rule. The essential services that practices are covering just now, within essential services, that is an eye examination if clinically necessary. For example, any key worker, HGV drivers, etc. If they need an eye examination, that can be provided through the essential care. And with regards to urgent and emergency eye problems, so say a DIY emergency or an eye problem, etc., they can be seen under urgent and emergency eye care. Those practices, the clinicians that are providing essential, urgent or emergency eye care, are only permitted to do so if they have PPE, if they are providing that within the 2-metre radius. That's the advice that we've been given by public health, and the PPE requirement for those clinicians are surgical masks, aprons, gloves and eye protection. Going on to the next slide. Develop a better understanding of conducting adequate and legal optical consultations during different forms of optical practice, restrictions in place due to COVID-19. So the GOC standards and the Opticians Act should still be adhered to when you are providing eye care. The GOC and other regulatory bodies released a joint statement on the provision of routine and essential and emergency care. And the GOC included in that support for guidance for clinicians to use their clinical judgment on providing remote consultations or prescribing remotely within their statement for remote eye care. Now that it wasn't detailed to the point where there were queries on the prescriptions. So for example, if a patient had a prescription that was, say, a month out of date, if it wasn't clinically necessary based on all the risk factors for those patients to be given new spectacles or contact lenses using that old prescription, then the GOC have said that they would support practitioners, registrants to provide that based on their clinical opinions. So this is to support practices to adhere to the 2-metre rule, to protect those in the shielded groups, etc., from having to go to practice when they can be provided care remotely, either by consultation or the provision of spectacles, contact lenses, etc. And all of the references to the joint statements, regulatory statements and guidance will be shared at the end of the webinar. Ensure that a safe environment is provided to deliver care to your patients in relation to coronavirus, and take appropriate action if this is not the case. What I'll cover here is practice adaptations, risk assessment, implementing protocols, overall decreased risk, and patient awareness. So internally, and I know that the other membership bodies have done this as well, or they're looking into releasing this information soon, is we are providing advice to all practices to do a risk assessment if they haven't done so already, to adapt practices and their protocols to provide patient care in line with public health guidance, to still adhere to the 2-metre radius and the use of PPE, etc. So within the risk assessment, we in ABDO have, hopefully tomorrow we'll be releasing this, we've provided a recommendation on considerations for practices to provide this care. And as I say, some are already doing it. And within the risk assessment, there are the 5 main points is to assess the practice layout with regards to social distancing, and mindful of staff and patients being in the practice, and the number of people that you can have within the practice and still adhere to the social distancing measures when staff and patients are there. The PPE requirement, hygiene measures for staff and patients, practice equipment, the cleaning of frames, equipment and the practice. Patient safety, we've drafted a pre-screening form, and I'll speak more about that in a minute. And also we're looking at, I think I said the PPE as well, yeah, so patient safety and PPE. So practice adaptation, some practices have already invested in the transparent screens for the reception areas, some communal areas, or the dispensing areas, and some have already looked at and have the germ guards on some of the equipment that they use, and they've implemented protocols when using that equipment in that close proximity to ask patients not to speak during that time, and they've provided guides for staff to adhere to that. So what our recommendations is base everything on that risk assessment, the practice adaptations that you can make, implement protocols to remind staff of possibly the hand cleaning directive, the use of PPE within the 2-metre radius, what staff will be required to wear that if patients will be asked to wear either a mask or gloves as well. Staggering appointments so that there's only so many patients in the practice at the one time. You're decreasing the overall risk there. When patients are trying on frames, provide hand sanitizer. They can use that when they enter the practice. Asked to use it again when they're selecting frames. And with regards to cleaning the frames, we would advise practices to adhere to manufacturers' guidelines on cleaning. However, there is a link with regards to cleaning of the practices' equipment and frames on the website. And as I say, for frames, please adhere to the manufacturer's guidance. And with regards to the patient's safety in the first instance, we've included with our recommendations paper a leaflet for practices to provide patients to inform them of the changes based on everything that I've said there with regards to how the practice will be set up, how appointments will be provided. And the fact that within the recommendation, if practices want to do so, they can provide appointments for everything, and that includes for dispensing, repairs, etc. So we've put all of that into a patient leaflet. We've also got a patient poster that you can put in the front of the practices, again to remind them that it's an appointment-based system. We've recommended that to support this for practices they can keep their doors locked. So we've got that. We've also got the back to the pre-screening form. That is that's recommended for practices to phone patients the night before to go through the questions on how the patient is feeling, to make sure that they're not symptomatic. And there's a list of the three main points: with the temperature, the cough, the loss or change of smell or taste. If a patient is experiencing one of those, they should be advised not to attend the practice and reschedule the appointment once they are permitted to come out of self-isolation. And there's a guide on that forum on what you should, the advice you should be providing the patient with regards to that. There is also another few risk factors that Public Health England have, Public Health have provided. So there's some other risks that if a patient is experiencing two of those symptoms, that they should self-isolate for 7 days. And this hasn't been written in stone, but I think that's down to the fact that the days of, oh, I'm not feeling that great, but I'll just plod on, or I had this wrong with me, but I'll just plod on and I'll do this and that, they need to be gone for the foreseeable. And anyone that is experiencing any of those, they self-isolate for 7 days. So the detail will be on the patient screening form for that. Moving on, examine the latest evidence available in relation to COVID-19 and optical practice and consider how this may impact your clinical practice. So, going forward, as restrictions are lifted, and we do not have a date as to when that will be, so as of today it still stands that only essential, urgent and emergency eye care is provided. When these restrictions are lifted, you need to think about everything that I've just touched upon, very top line, and what you can do to make your practice as safe as possible for your staff and patients to provide routine care based on all of the considerations that will be in the recommendations, which I've touched on there. But as I say, tomorrow, hopefully Abdul will be releasing the recommendations for considerations. So going forward, for routine care to be provided, the two main points is to adhere still to social distancing and the requirement of PPE. Shielded groups, there is a link on the Public Health website and also on the Abdul COVID page on the information that's being provided to shielded groups, which is different from all others. Not the social distancing or the PPE requirement, but actually shielded groups have been advised to self-isolate for longer, and it may be even longer again than the rest of the population. So what the OFNC are doing is we're working with the representative bodies throughout the UK to look at how eye care can be delivered to these shielded groups, either in their homes or out with. And when we are providing routine care again, what we would suggest is that the shielded groups, they can be invited into practice, but it may be that you dedicate a day or a morning or an afternoon to those groups specifically, bearing in mind that they have been advised to not use public transport. So that's why we'd like all staff to be aware of the advice that's been given to the shielded groups. And as I say, we're looking at how we can provide care either in their homes, obviously with the PPE, and out with long term for these groups. And also with regards to the routine eye care, there will be a number of patients who should have presented to practices during the lockdown for routine eye care. And obviously, depending on all risk factors and for those presenting when the lockdown is lifted, consideration should be given to try and prioritise those groups to get them, if they're able to come into the practice, etc., to get them seen, because obviously the routine eye care picks up any underlying problems, etc. So just be mindful, I'm sure practices will be, but be mindful of prioritising getting those patients seen sooner rather than later, obviously considering all others that will be invited back in. Sorry, something's flashing on my screen here. Yeah, so be mindful of that with regards to the those that were due to come in for routine care during the lockdown phase, and also provisions for shielded groups. So it's very top line, and I think I've touched on most points, and I'm still within my half an hour, so I don't think I've got anything more to cover here. I'm sure there will be a lot of questions that hopefully I'll be able to answer at the end of this. So yeah, all references and links will be provided at the end by Alex. And if you just give me a minute, I'm going to stop sharing my screen and hopefully hand over now to Dean Dunning, who is our ABDO Chief Examiner of Contact Lenses and Programme Lead for Ophthalmic Dispensing and Contact Lenses at Bradford College. So over to you, Dean.
Thank you, Debbie. Now I'm on camera. I just need, if you give me a second or two, just so I can present right. There we go. So yep. Hopefully you should be able to see my screen in a second or two.
Yep, that's you, Dean. So you're the presenter. Over to you.
Okie dokie. Thanks. Now, I'd like to say thank you for Debbie. A lot of what I say is very relevant to what Debbie's already told you about, so I hope I won't repeat too much of the same things, but all of the advice that Debbie's already given you is relevant to contact lens practice as well. But if I can just make sure you can all see my screen. Oh, that should be sharing now. Yeah, great. So I'm going to just take you through a couple of little bits. While it's not quite policy necessarily that I'm going to be talking about today, I just want to have a little look at some of the literature that's been going around with regard to contact lenses, because we've worked at a pretty big pace really to try and get some information out there. Now, what I noticed was, I think it was on something like Twitter a little while back, that something on the Twitter feed had said, doctor recommends that you should not wear contact lenses until coronavirus is over and done with. And I thought I'd do a little more of a searching on that. I found it all quite interesting. One thing I've noticed from the literature, had a little bit of searching around. So it's an example. It's an American site, but CNN, there's an article saying switching to glasses from contact lenses will stop you from touching your face. I guess that's probably true. But when you read the story a little bit more, it's based on the American Academy of Ophthalmology guidance, which does state coronavirus can spread through the eyes. Their advice went a little bit further and did suggest in this time that we should all consider switching to glasses for a while, for the simple reason that if we are wearing contact lenses, we are far more likely to touch our face and our eyes, so we are more likely to transmit coronavirus. Now, clearly, to some extent, that's correct. We are far more likely to touch our eyes, touch our face, and so on and so forth. Does that mean that we should be stopping all contact lens wear during the time of coronavirus? Because this could go on for quite a long time. I think what we've tried to do is have a look at an evidence base regarding this, and perhaps the most important document that's been written about it is from Jones et al., which is in contact lens and anterior eye, and they've looked at it from a slightly different angle, and they've pointed out that as things stand, there is no evidence of an increased risk of contracting COVID-19 through contact lens wear when compared to spectacle lens wear. So there's no evidence of it. Now, clearly, contact lenses, we work on a very much an evidence-based practice, and the lack of evidence may be to do with the fact that we haven't had enough time really to do enough research through it. But at the moment, this advice saying that you shouldn't wear contact lenses is not based on evidence at the moment. There's also no scientific evidence that wearing normal prescription spectacles gives any protection against COVID-19. So even though we've seen sort of, safety goggles and so on and so forth, it had been mentioned in some news stories that actually wearing your spectacles makes you less likely to touch your face because you've got a barrier in the way. But again, there's no scientific evidence that wearing standard spectacles provides any protection. We're quite lucky really in contact lenses that most contact lens wearers, I'll say most, do follow really good hand hygiene. We're taught from a very, from the initial examination from the teach, that hand hygiene is absolutely vital if you want to carry on wearing contact lenses, not necessarily to do with COVID-19, but to do with bacterial infections and so on and so forth. So the fact that we now have coronavirus, obviously a very serious virus, meaning that we need to wash our hands, for 20 seconds and so on, while we're singing Happy Birthday twice. Really, it's something that we've been used to doing anyway for contact lens wearers. We should always be washing our hands thoroughly. And then if we are touching our face, which we are when we're inside our contact lens and so on, we're actually limiting the chance of transmission to the ocular surface anyway. What the study has gone on to point out is that if you do show with symptoms of COVID-19, that really it's not the right time to wear contact lenses. Obviously quite basic, simple, straightforward advice. So if you have symptoms of COVID-19, then you shouldn't wear your contact lenses. And if you do develop symptoms of COVID-19, it's recommended that you immediately dispose of any lenses that are being worn. And because you may well have touched if you're using a monthly lens where there's cleaning solutions and so on and so forth, that you should dispose of your solutions as well in any contact lens case. In the same way if you developed a bacterial infection. The key thing I think in the article pointed out was that even now, the article is probably the best part of, was published about 3 to 4 weeks ago. The information is coming out at a really, really fast rate. There's likelihood there's going to be several papers released over the next few weeks and months and so on and so forth. So while webinars like this are really important to get some information, there's every chance that in the next 2, 3, 4 weeks, 8 weeks, 12 weeks and so on, there'll be new information out there. And it's our role as eye care practitioners that we need to be aware of what's new out there. We need to keep looking. We need to keep making sure we're reading the optical press. We need to keep making sure we read our optical journals and so on and so forth, because we are really trying at a very rapid rate to try and find new information. I just want to point out from the same edition of Contact Lens Anterior Eye, Zeri in the room made a few key points, and this goes back to a few of the things that Debbie was saying. The key thing is that we are trying to limit the patient's attendance in our practices, and that's for the safety of the patient as well as the safety of the staff and practitioners. So we should be making every effort to try and lower patient attendance, and I'll speak very briefly later on about some of the things that we're doing to try and action that. When there are a particular patient makes an appointment, we need to evaluate the risk that they may pose. We should really be asking questions of them if they wish to book an appointment. And Debbie had alluded to it earlier. Do they have a cough? Do they have a fever? Do they have any of the symptoms that might suggest that they have COVID? If they do, we should be trying to prevent them attending practice at all costs, really. And that goes as far as if they have something like conjunctivitis. Because again, there's that risk that conjunctivitis may well be viral, transmitted through coronavirus to the eyes. So if they have any kind of pink eye and so on and so forth, we should be trying to prevent them from attending the stores. I'll speak a little bit about PPE. Clearly, it's been discussed a fair bit by Debbie there about the sort of personal protective equipment that we should be wearing. And you've seen the little picture that was shown earlier of the face mask of the patient and the face mask of the on the practitioner as well, and the staff and so on and so forth, whether it goes any further. And I want to speak very briefly in a couple of slides about one little bit of a study that's looked at what practitioners think should be worn for PPE. Hand sanitization, I think it's a fairly straightforward one. We should be sanitizing, washing and disinfecting our hands before and after all patient contact. Now clearly that means a lot of hand washing, a lot of hand sanitizer, but these things need to happen. And that is any kind of dealing with any patient. If you're going to come into contact with anything else, if you touch your own face and so on and so forth, which goes on to the next point, we need to do everything we can to avoid touching our own face. Easier said than done, but I'm glad my camera's not on, because I think I've probably scratched my chin about 4 or 5 times since we've started. So something that you see people doing a lot if you sit up and take notice of it. But we need to really be aware of trying to avoid touching our own face. And as soon as we mention don't touch your own face, I'm sure the 678 of you is attending at the moment. I'm sure about 600 of you are thinking, I better not scratch my chin. The other thing I want to point out is the disinfection of contact lenses. Now, in vast majority of practices, the reuse of trial lenses isn't particularly commonplace, but there are going to be several practices that specialize and fit things like keratoconus and so on and so forth, where we do need to disinfect trial sets. But the disinfection goes further than just the contact lens. It goes onto our equipment and so on and so forth. We need to be using the full disinfecting regimen that we normally would, such as the sodium hypochlorite, 70% alcohol, so on and so forth. We should be using the disinfectant measures that are recommended by the manufacturers. And again, just to repeat what David mentioned, if there's staff with any type of flu-like symptoms, when in the past we might have said, oh, we'll go into work, I don't want to let anyone down. Really, we're letting people down if we do go into work, if we've got symptoms. So it's very important that staff presenting with any type of symptoms such as that, even if they don't directly fit the COVID profile, shouldn't really be attending work. Based on sort of this editorial, the IACL, which is an International Association of Contact Lens Educators, so they have a big worldwide body of members. They've issued some advice for clinicians, and I think it's worth just covering it quite briefly. Although their main one is we should follow our own national regulatory bodies. And clearly we've had guidance published. There'll be more guidance published soon, and Abdul will be publishing things in addition to it from tomorrow. rescheduling non-urgent and new contact lens fitting appointments. Now this is a key one, especially come from someone like me who deals with contact lens examinations and contact lens trainees and so on and so forth. I think the key one is anything that is routine and they don't need to be in practice shouldn't be in practice. And that goes for new contact lens fits. So we shouldn't at this stage necessarily be encouraging new people to try contact lenses. Now, not very good for business, but the simple fact is that most new routine fits, we have to ask the question, are they essential? And at this moment in time, if they're not, then we shouldn't be encouraging it. Now, clearly there are times when new contact lenses will need to be fitted, and we're talking about things like bandage lenses and so on and so forth. So this isn't a sort of blanket advice, but routine new contact lens fits at this moment in time are perhaps to be discouraged. Some of them are, I think, are very straightforward, and I think we can cover them quite quickly in that we've got trying to reduce all physical contact with patients. Now, in contact lens practice, that's easier said than done. If you think about sort of averting eyelids and so on and so forth, you know, lifting the lids, pulling the bottom eyelid down so you can assess sort of the conjunctiva and so on and so forth. We should be trying to limit that as much as we possibly can. Certainly with contact lens teachers and so on and so forth, we really, in contact lens fittings and appointments, we need to think, do we need to be putting the lens in a patient's eye? Because that would often happen, but actually they're going to need to put lens in their own eyes eventually anyway. So do we need to be doing it for them? Should they be doing it themselves immediately? Albeit that we are trying to limit new contact lens fits anywhere. And again, they mentioned that the PPE is appropriate, maintaining social distancing. And a couple of things towards the bottom there, again, trying to minimize the impact on the wider healthcare service. So obviously we have lots of systems in place, and there was an excellent article in Dispensing Optics this month about sort of some of the MEC schemes and so on and so forth. We should be trying to utilize, you know, the primary care that we have there to try and ease the pressure on our healthcare system. And once again, IACL have also recommended that new findings are highly likely to emerge at a pretty rapid rate, so we need to be wary of it. Now, a couple of other little things. I think that those are some of the main advice that went around, but I think there's a couple of quite interesting points. This isn't United Kingdom or Great Britain, but Heiko Pulse surveyed a number of eye care practitioners in sort of Germany, Switzerland, and Austria area to get their idea about how they felt about PPE and so on. Quite interesting was that 69% of those practitioners who were surveyed planned to use masks. So this wasn't necessarily are they going to follow the law, this was what their opinion was and how they felt it was workable. So almost 7 in 10 suggesting that they would want to use a mask when fitting contact lenses, and almost as many, 62%, so not quite as much, would expect the patient to use masks in the same appointment. And obviously we saw from the photograph earlier that we had a patient and a practitioner both wearing face masks. I think from a safety point of view, clearly it's quite important, but what was interesting was that less than a third would want to go further than that, particularly. So less than a third would rather use face shields or safety goggles or protective gloves and things like this. So I think we may have an issue further down the road about exactly how far we take the personal protective equipment there. I mean, as I said, this study isn't in the United Kingdom, but it may well reflect, and unfortunately, if we had the polls run tonight, it might have been an interesting one to see how we all feel about it. Clearly, it was mentioned earlier about how we can, if you like, make changes to our practice to make ourselves less at risk. Here's just a little example of the Royal College of Ophthalmologists telling you how to make your own breath guard. That was an A3 laminated sheet that they put through the laminator without any paper inside, you know, that you laminate this, you know, the sort of piece of paper with. So you laminate it and then cut a hole out of it and slide it over your sit-lamp eyepieces. So quite rudimentary, but You know, these are things that we can do to try and protect ourselves as much as we can. There's other companies who've discussed the sort of possibility of issuing free breath guards and so on and so forth, and they are well worth taking advantage of. I think one of the key things that have been alluded to was how we stop patients coming into practice wherever possible. And this template, which was in collaboration with a number of bodies, including ABDO, which is a pretty solid, in my opinion, if you like, record card to use for a telephone review. Now, this is clearly, we've been given guidance to use our professional judgment wherever we can, but our professional judgment should be mindful that we're trying to limit these these patients going into practice. So this is a pretty good template to be able to use. And you can see, I won't go into a huge amount of detail depending on what sort of device you're looking at this on, but there's patient education checklists so you can maintain the fact that you're trying to stop them using sort of tap water and so on. You're not sleeping in them. They're trying to minimize the risks as much as you can. Clearly, a telephone review is not a substitute for a physical appointment where you can actually physically examine the eye. It's very much a means in the short term to still provide our patients with contact lenses wherever necessary. But it's probably well worth looking at how we're going to look in the future if this goes on for a lot longer than we might have perhaps thought. And by that I mean that if we start going on to sort of 6 months, 9 months, 12 months and so on, for how long are we going to be able to still continue just providing telephone appointments? Now, unfortunately, this is a great paper, Nagra et al. Well worth a read, but it was looking at telehealth and how we can use devices to try and examine the eye remotely. And I think they've pointed out that this period of which normal eye care has been, if you like, suspended, we have no idea how long this is going to last. So this is going to quickly hasten the need for sort of practitioners to adapt the way that we deliver eye care. We don't know what's going to happen. Maybe that, you know, that this first spike is dropping down. Maybe we will go into practice again. Maybe the second spike will happen. We just don't know, simply. So I think a lot of work looks like it's going to be done regarding this. At the moment, there isn't a big enough evidence base for this. It's come a little bit too soon for us, really. So clearly there are devices out there which can be used. There just isn't enough evidence at the moment to let us know how effective they're likely to be. Therefore, because the pandemic has come on us so quickly, perhaps we aren't quite ready for it yet to be using things like iPhones to examine the eyes and so on and so forth. And they have pointed out that contact lens practice, while we are using telephone consultations at the moment, contact lens practice isn't really a discipline that lends itself well to it. Simply, we do need to examine the eyes. Patient examination is central to clinical decision making. And while a lot of work is going on to how we can use software and so on and so forth, like we're seeing so often the technology in practice, at the moment, we don't have a system where it can replace sort of our own clinical decision making. I've just about come to the end of my little bit. We're more or less to time, aren't we? So there's a big list of references which is available to download in the handout section. But I guess now is probably the time that a lot of you have been waiting for. So I'm just going to come back on camera, that's okay.
Hello, Dean.
Hi, Alex.
Right, let's see if we can get Debbie on. We've got a lot of questions, guys. Okay, let me see what time we've got. We've got plenty of time to cover these, that's fine. So I'm going to start with contact lenses. I've got literally pages and pages of questions here. So I'm going to start with contact lenses since we've just covered that bit off. But in the other section, I think both of you could probably chip in, and there's some clinical stuff as well for that Dean might cover. So, right, regarding contact lenses, how do you think the GOC will overcome the issue of contact lenses during this time? Will there be any additional competencies put into the standards of practice to ensure they've been met? I'm not 100% sure on what this is going at, but I think that although the GOC have given us some relaxed guidance that there won't be any permanent changes, because obviously there's some issues regarding legislation, etc. But I don't know what your thoughts are on long-term changes, GOC advice, etc.
Well, I think obviously when the GOC suggested that we should be able to use our clinical judgment, that was very welcome, because I think, you know, we are professionals, whether it's optometry or contact lens opticians and so on. We need to be able to look at and make our own judgment on each individual case. I think long term, clearly the GOC are in the midst of an educational strategic review right now, so they're reviewing things anyway. It's almost come at a strange sort of time, but it might be helpful. Do I anticipate any longer term change to competencies and so on? Well, I think competencies will eventually disappear anyway over the next couple of years. So I would suspect that the educational review is probably the beginning of them looking at ways in which there may well be changes to how we practice in the future. In terms of what those changes are, I'm not 100% sure.
So hopefully maybe we will see some permanent changes regarding the changes we've had to our practice now, to take them into account. Yeah. Mm-hmm. Okay, will we be able to conduct contact lens teachers in the future? This came up quite a few times.
Again, I think I sort of alluded to slightly. I see no reason why not, except that when we are doing the teach, we are maintaining our distance from them. They are putting the lenses in themselves and taking the lenses out themselves, so we're not having any physical contact with them, which clearly is difficult. But
yeah, so as a CLO myself and a CLO yourself, how close do you get to your patients when you're doing a teach? It's close, isn't it?
Yeah.
Yeah. You know, and obviously thinking about the fact that people need, you know, at those early stages, sometimes you need to be taking that lens out of a patient's eye, which again, maybe a different situation for us as a CLO rather than if we had a teach under our supervision, as in it might be routine for an optical assistant or a dispensing optician to do that teach for a CLO. Would we be allowing that to happen, do you think, as a delegated function?
Again, I think the key part is how do we keep everybody safe through it, both the patient and the practitioner. And I think Debbie's got something to.
Yeah, come on,
Just
Debbie.
to add to what you're both saying, with the discussions with the GOC, is that it may be that they regulate and they put into the standards the use of PPE for students, for the teachers, and for patients going forward in practice.
Okay. So, and this comes up a lot as well. We'll I think you'll cover that off a bit more about PPE and some of these things that we're doing. So back to similar sort of question, but a little bit different. So regarding practitioners putting lenses in and out of patients' eyes, and again, obviously when we don't have to do that, we're not going to be doing it, but in the circumstances that we know, sometimes we come out when we need to put a lens in somebody's eye or we need to take it out of somebody's eye, and obviously most of the times when we're putting it in, it is going to be for a new patient. But would we be expected to be wearing gloves to do that, or is it a case of doing it and hand washing? What do we know yet? What the circumstances on that will be?
Dean, do you want to take that? Do you want me to?
Yeah. So I think the expectation is certainly in short term that yes, gloves will be expected. Even though, like we say from the Pulse study, that probably gloves aren't necessarily welcomed in practice. That I think certainly short term we're going to have to expect to, if we are to put a lens in somebody's eye. And like I say, I think the key thing is that it's the putting the lens in somebody's eye that should be the last resort almost. And if it's a simple case of it's a new fit and we have to put the lens in because the patient can't put it in themselves, then we have to look at how essential was that in the first place then.
Okay.
And if it is something like a bandage lens, then it's slightly different.
Nope,
Debbie?
just to add to that, again, some mixed professional opinions on that. So some do say to use gloves and some say that hand washing is better, and that if you follow the hand washing procedure before and after every patient that you're seeing.
Okay. And certainly if I was putting them in with gloves, I'd probably practice it on myself first, maybe, just to make sure I knew what I was doing. Okay, would a patient be better wearing dailies over monthlies or RGPs at the moment, do you think?
Well, the Jones study suggested that dailies are perhaps, a better option, because we're limiting our use to them for single use. They're being handled as little as they possibly can. But clearly, daily disposables aren't a panacea. They're not a cure for everything, and the limited range of powers and so on, and prescriptions and so on, will mean that I think wherever possible, that daily should be encouraged, and that the handling of a contact lens should be minimised as much as you possibly can. So there's certainly no substitute for being able to wear a lens once and then throw it away. But we also have to have faith in reusable lenses and the contact lens solutions that they are using. And if the solutions are used effectively and to the full manufacturer's instructions, then there is minimal risk of transmission.
Okay, and I suppose we've got some patients who just couldn't wear dailies, haven't we? Because
Exactly,
they're not available for them. So best interest of the patients.
Mm-hmm. Yeah, I think it has to be taken on a case-by-case basis. And if they do happen to have sort of large cylinder or particularly high powers or so on and so forth, or if it's something like keratoconic, then clearly there isn't a daily lens that can work for that. So I think it needs to be on a case-by-case basis, but daily should certainly be encouraged.
Okay. Any studies looking into the effectiveness of all-in-one solutions versus peroxide with specifically regard COVID-19? If we were recommending a solution to a patient?
It's a question I don't have the answer to. There's certainly studies going out there at the moment looking at the efficacy of different types of contact lens solutions and so on. Whether any specifically looking at it in light of COVID, that I'm not sure about. Certainly when in the regimen tests anyway, they need to be effective against a certain amount of viruses and bacteria and so on and so forth. So whether there's a particular preference for COVID, it will be very interesting to see. But again, a study like that will take a little bit of time, because it needs to be based around sort of different lenses and the compatibility of different lenses with different solutions and so on. So again, I'd be a little bit wary about saying, use peroxide or use an all-in-one or so on and so forth, because it can vary from lens material to lens material.
So we'll keep our eye out and see what the manufacturers are saying as we go on with things.
I think so. I think so. And what they're obviously in the best place to do it. But I would suspect that there are studies going on there, but certainly nothing that I'm aware of where results are likely to be out anytime soon.
So I've got a couple of questions that have come through, or a few questions actually that have come through specifically regarding contact lens exams. So really putting you on the spot now, Dean, which you may or may not be able to answer these, I'm not sure. But do we have any guidance for trainee CLOs preparing for practical exams when COVID allows us? So when we're able to do those exams, do we have any advice to them regarding their interaction with patients?
Well, I've only been like the chief examiner for around 3 months now, something like that, less than 3 months, just about 3 months. And so far, I think I've just been responsible for cancelling lots of exams and lots of exams. We're well aware that we're in a very complicated situation at the moment. We issued some slight guidance changes for those students who are currently in the system, who were due to sit exams shortly or may have resits or anything like that, we would allow them to limit the number of appointments that they saw. We're acutely aware that certainly the students who have started on the 2019 syllabus, so are doing the course at the moment, where the first opportunity they would have got to sit their practical exams would have been winter of this year, or rather January 2021, that we're well aware that they're going to find it very difficult to get the case studies in place to meet the guidelines. Now, we are looking at ways in which we can try and, I'm not going to say make the situation easier, but more possible for for all the contact lens trainees out there to be able to at least sit the examinations, but it's something that takes a lot of doing, because we still need to satisfy GOC regulations for training and so on and so forth. So it's unfortunately, it isn't something that's going to be changed overnight. It's not something where we can just say, oh well, for the time being we're going to lift our restrictions. We need to make sure that at the end of the day that a trainee contact lens optician is still fit to practice and safe to practice, which means we need to be able to see them having the experience. But we're well aware of how difficult that is in these times of COVID, especially in light of me saying, don't fit anybody new with contact lenses for the time being. So at the moment, it's a bit of a watch this space. I hope to be able to issue some more guidance in the mid to near future.
Okay, lovely. Do you anticipate that contact lens exams will be updated to include specifically in relation to COVID-19? So obviously we're changing our practice, or we're talking about changing our practice. I mean, as I say, I'm a CLO and I have no idea when I'm going to be back in practice seeing anybody, but it's going to be different when I am. So do you think that that will be taken into account in the exams, or when that might be taken into account in the exams? Because obviously those students who have already at the exam process, they've already done all their studying in a way, haven't they, sort of thing?
They have. At the end of the day, a student who has started the course is running to a particular syllabus, and it would be unfair of us to then say you now have to change your practice to cope with this. However, based on that, we've always spoke about on the syllabus about hygiene and so on, and safe practicing and patient care and so on and so forth. So I think maybe adapting how that is to take, if you like, under advisement everything that's happened with COVID, then I would expect not necessarily a change in syllabus, but certainly we may well expect to see, you know, whether it is things like PPE or whether it is, if you like, more strenuous regulations with hand washing and so on and so forth. But that's what we were expecting anyway of our candidates, is to practice very good hygiene in almost the same way. So I think in many ways, even though we've said contact lens practice is going to change forever, I still think the basic fundamentals are the same. That if we practice the right hygiene, and that's disinfecting, you know, our hands, washing our hands between patients and at any stage when you're touching your own face, then theoretically we can limit exposure and transmission anywhere.
Okay, lovely. Okay, an interesting one. What about if we have a doctor or nurse who's looking to have a new contact lens fit? They're wearing, you know, if they're in a position where they're having to wear full PPE and they feel that it's going to be better with the contact lenses, which is very, very possible if they're a spectacle wearer, should we be seeing them?
Well, again, I think because we're talking about a patient by patient basis, we could argue that that's an example of perhaps something that may well be essential. If they are a doctor or a nurse and they're finding it difficult to wear their prescription spectacles because they're wearing something over the top and it's impeding their work, then that for me may be classed as a very good reason to fit contact lenses. Should we be fitting them? Well, again, if you think of the advice that Debbie mentioned earlier, if they're showing symptoms, then absolutely not. But if they're not showing symptoms and there's a good enough need for it, and we're taking it on this patient by patient basis, then I'd like to think that once we get some kind of normality, and that we should do what we can, because that's going to allow them to do their jobs better.
Okay.
I would echo that, Alex, to support what Dean said.
Okay. And last one, specifically regarding contact lenses and keeping you under the spotlight, Dean. Will colleges, plural, be taking on new contact lens students in September if new fits are not possible?
Well, I guess I can swap my hat now, can't I? And because at this moment in time, absolutely, we realise that businesses might not be quite in the same position to necessarily put students through, but we see no reason why we need to sort of prevent people's studies. Certainly, it's well worth pointing out that there's a lot of theory behind contact lens as well as practice. We do anticipate contact lens practice will return at some stage. It might be in a slightly different way, but there's still going to still going to be the need for contact lens opticians, and people are still going to need, you know, aftercares and so on and so forth. So yes, we do anticipate the colleges still running their contact lens courses, but again, with these things, it does tend to be about supply and demand. And if there's enough demand for places on contact lens courses, then I fully expect the contact lens courses to run, albeit they may run differently. And there may well be more of an emphasis on the theory side before we get into the practical part.
Lovely. Okay. One that came through when you were talking, Dean, but actually it's really, I think, both of you or Debbie maybe, are we able to refuse to see a patient if they have symptoms?
Yes.
Yes. Okay.
They should be advised.
That's a good answer.
They should be advised of the self-isolation rules with regards to 7 days and 14 days.
Okay, so I'd say no, you can't come in.
You are, yes.
Okay, there's another question. I'm really sorry because my questions aren't in any sort of topic order. They are literally as they came through. I'm going to try and sort this out. But
Alex,
there was another...
I should maybe add to that if it is absolutely urgent, then it may be that the patient is referred accordingly with regards to those that are providing urgent care with the PPE. Okay, so
you've got a patient who's got an ocular emergency.
Absolutely, it may be that they need to be referred either to an emergency eye care treatment centres, for example, in Scotland, or to secondary care or what have you, with regards to the in line with the PPE requirements in those establishments. Yeah.
Okay. So yeah, and I think no, that's fine, and I think that is yeah. I think the question was potentially in relation to when we are open again, and when we've got patients possibly coming in for routine sight tests, and we're asking those questions about, do you have symptoms and stuff, and they're saying no, but then they turn up maybe and they do. But yeah, ocular emergencies still need to be dealt with. Yeah.
Yes.
Okay, this question was asked a lot of times. When do you think routine eye exams will resume? And a second on that is, what sort of notice do you think we might have?
I'm hoping that we will have at least up to 4 weeks notice. However, I really don't know, because it's different depending on which part of the country you're working in. So I know that Scotland are looking to communicate on easing restrictions, I think on the 28th of May. That's looking at providing advice or guidance on the planning for easing restrictions. I'm working with OFNC colleagues and NHS England on the same for England specific. The College of Optometrists and the representative bodies, including OFNC, are looking at the guidelines on infection risk through the government's sort of traffic light system, and so the clinical advice will be updated shortly on the provision of routine care, and then hopefully that will all be able to be adapted when we're given permission to provide that. So hopefully, I don't want to put a date out there, but I'm hoping that we'll at least have 2 to 4 weeks notice. And as I say, that's why we are working internally at Optical to provide the patient leaflet, the posters, the recommendations for consideration, just based on the timelines just now that we are looking at.
What is and again, I don't know if this has been finalised or if it's might change for routine. So obviously we've got, you might be able to answer this for what the current situation is, but what might it be in the future? What's the recommended PPE? So we've got recommended PPE and thinking of the different professional roles. So there's the role of the optometrist and the contact lens optician who would be in the testing room potentially, but also recommended PPE for the dispensing optician.
Okay, so the current advice from NHS Public Health is that any clinician or social care worker providing care within a 2 metre radius, they should be wearing a surgical mask, apron, eye protection and gloves. That is the current advice for all.
And that would obviously fit for a dispensing optician as well, because you would be providing that care within 2 meters.
Yes,
if you're going to be dispensing somebody.
Absolutely, that is the advice, the public health advice out there.
I've got a couple of things on PPE that I'm see if we can cover this one as well. Sorry, so I'm just trying to pick through my questions. Eye protection, own specs, is it adequate? Do we need specs over the top, visors, masks? Do we have masks with specs underneath? Do we know what that is, or is there somewhere telling us where that what the details of that are? So if I'm a spectacle wearer, can I just wear my own specs? Is that good enough? Okay, do I need a specific type of safety spec? Do I need a goggle? Do I need a visor?
Yeah, so the specification with regards to the goggles is included in the PPE advice on the public health website that can also be accessed through the COVID-19 page on our website, the ABDO website, and that's for the goggles, etc. What was the second part of the question there, Alex?
I think you've answered it. That's fine. We can't wear our own specs, but that's where so if we go into the ABDO web pages and we can find our way through to the specific details on what goggles or eye protection we would be wearing.
The goggles, yep, that are completely inclusive of the sides as well. And going forward, I have asked the question of public health if full face visors without the surgical mask would be sufficient for the dispensing opticians within the dispensing area. So we will wait and see, but currently the advice as it stands is relevant to all contact lens opticians, dispensing opticians and the optometrists. Okay.
Right, let me just have a look. Okay, so if you are an ABDO member, a dispensing optician or an optometrist or contact lens optician who's in the high risk category, and you know that you are not going to be able to social distance. So if you go back to work, you're not going to be able to socially distance because obviously we know our roles are within that 2 meters. You want to work, but you don't want to be exposed to high risk. What should we do?
So we're hoping that employers will all be mindful of that, and those that are in high risk groups and those that live with the high risk stroke shielded groups of patients. And it may be that they, even if they're not a registrant, if it's an optical assistant or the reception, etc., that they will they'll do a risk assessment and provide PPE accordingly for those staff members.
Okay. Should we be using fresh mask, gloves, apron per patient? Or is there somewhere that will tell us the rules?
Yep. So there's specific guidance on donning and doffing the PPE and how it should all be used and how it should be disposed of, and it's all on the link that's provided on the public health website and also the ABDO website, and it will be reiterated again in the guidance that we provide with the recommendations paper tomorrow.
Okay. So this, I thought it was an interesting question. Is a practice allowed to require patients, including NHS patients, to pay for a retinal scan in order to undertake an eye exam? Now, there's not full information maybe in that question for us to understand what else would be included in that eye exam. So I think there's an interesting thing is that possible, but also is that an eye? It's obviously not a full eye exam, so I don't know how you want to answer that.
I'd need to know more detail on that. I don't know if Dean would want to come in on that, but with regards to like maybe OCT imaging and things that practices do, some practices do charge for that on top of an eye examination, but I'd need to know more of the detail on that.
I think the question is maybe considering how much you can do from a retinal scan, so how much that could replace, for example, ophthalmoscopy, so that maybe you're not spending as much time with the in that 2 meter distance. I suppose the pre-screener probably still has to get within 2 meters. Don't know your thoughts, Dean.
Yeah, not a huge amount about it. It's obviously it's a bit of a grey area. Certainly, clearly, ophthalmoscopy is one of the areas where you get probably as close as you're ever going to get to sort of in this line of work. And yes, you can have a bit more of a distance if you're using something like, you know, retinal imaging and so on and so forth. But whether that's, I wasn't quite sure about whether that means replacing part of the sight test or whether that's replacing the whole of the examination.
Not clear. And I think there are issues there, aren't there, as to what you still have to do as part of that routine sight test, which obviously any optometrist should have that full guidance coming from the College of Optometrists, I would have thought.
Yeah, it's on the website.
Okay. Is there a limit as to how long a prescription can be out of date? So this is thinking about obviously where we're currently doing, you know, maybe our tele dispensing or care. How long can that prescription have been out of date? Are we okay just using our judgment as long as you've done all the note taking, etc.? And obviously this is just people being really concerned about making sure they're covering themselves in that professional judgment.
Yeah, there has been no detail on the limit with regards to the prescription, and the advice in the statement that the GOC released, and Dean can correct me if I'm wrong there, but from memory there is no limit in there. It's based on the individual patient, the risk factors around them, and the clinical judgment of the optometrist or dispensing.
Yeah, 100% agree. Yeah, that's what the advice is. Doesn't be any time limit on it. I guess the key part is the professional judgment part, being able to make our judgment. And, you know, I guess if it was something like 10 years on a contact lens prescription, and, you know, and we were still supplying contact lenses, then clearly the clinical judgment will be brought into question. But in terms of a time limit, there isn't anything. I guess the key part of it is that if you are going to supply a product, whether that's spectacles or whether it's contact lenses, to an out-of-date prescription, even in these times of COVID, it's very important that you make your notes very, very clear about what you've done, why you've done it, why in your judgment it was the right thing to do, in the best interests of yourself and the patient. So the time limit, I'm almost glad that there hasn't been a time limit put on it, because that might make things more difficult. I think the professional judgment part is key to all that.
Okay, lovely. One question is about thoughts when we do come back to our practices opening, around maybe having staggered start times. If we've got multiple clinics, do we consider something like that, or are we best just to have normal opening times? Any advice on that? I think obviously we probably might see different things happening.
Yeah, I think it's going to vary depending on the practice setup, but there'll be an element of the need to stagger the appointment times to allow for cleaning in between patients and at regular times, maybe in the morning, afternoon, and the evening, to do that. And then there's depending on the patients that's coming in, when I'd said about maybe having shielded groups, and it may be that you give longer times in between patients so that there is you decrease the risk of any infection, and mindful to be sensible about it all, because we are maintaining that any patients that are symptomatic, they don't attend the practice, etc. So yeah, it may be that for example in England that practices extend their or wherever really in the UK, but with regards to the contracts, that they extend the opening hours within their contract to maybe see more patients in the interim once we start to provide routine care again, to make sure that they can still see, as I said earlier, those patients that maybe were due routine appointments during lockdown, and those that are now due those when we come out of lockdown, that are due those appointments too.
Okay. I've got absolutely loads more questions, but we're running out of time. I'm going to ask you a couple more, and then I think one of the things is a lot of these questions can be answered, I think, within the Abdo pages and the signposting there. But also, I am going to make sure that Debbie and Dean have copies of these, and also Antonia, who obviously is head of our communications, to make sure that any questions that are there, people will have the opportunity potentially to have that answered in those FAQs that I know are on the webpage. But last couple before we all go off for our evening. What's the procedure if a staff member contracts COVID? So you're open, somebody gets COVID. Do all employers self-isolate? Does the practice close? Do we know what might be seen there?
Okay, so there is guidance with regards to, so if a member of staff, so the example I'll use is if they've been in practice and they go home that evening and they start to feel unwell, the practice, hopefully everyone, is applying the cleaning procedures. And again, this is all in the recommendations for all of the public space, work surfaces, phones, etc., etc. So that's decreasing the risk that if they have been in the infectious stage when they've been in work, that the practice is cleaned, and that they are mindful that if any staff starts to develop symptoms or feel unwell, etc., that they the recommendation is that they self-isolate too. So that's the only sensible advice I can give currently on that.
Okay, and just last one was just because I know you have the answer to this one. Just somebody's asking again about that, where they source PPE from.
Okay, so PPE throughout the UK should be available to all optical practices through the NHS supply chain, but we know that the resource there is very scarce, and some practices are having difficulties in obtaining it through that resource. So there will be a list on the ABDO website tomorrow of suppliers of PPE, and I would reiterate again the importance of the standards of PPE, and that they meet the UK standards and have the CE marking on any PPE bought. So I'd everyone be mindful if you're going to external suppliers out with the NHS supply chain.
I think it's the same as if we were saying to a patient, don't go and buy your sunglasses from somewhere else. It might not have that CE mark on and be of the standard we want, isn't it? You know, we know what standards we have in the UK, and that the CE mark is very important, isn't it? That things are to the standards we would expect. Yeah.
Yeah. Yes.
Okay. So as I say, I'm going to make sure you guys have copies of these questions. Do, if you're able to, if you haven't already done it, download that referencing guidance list, also the reflective statement if you want to make some notes there. Have a look. There's lots and lots of websites that can signpost, because I know there's more questions out there. The other thing is always we have our membership department, and they are able to very much either answer some questions on the spot, but they can certainly signpost you again, whether it's legal advice, etc. So, you know, contact, there's Katie and Ed working in that department there, working very hard, and so ABDO certainly can help you with all these questions, and ongoing as we have things changing. The website will be continuously updated, won't it, Debbie, with all that information as we go on. I will also be looking for us to have the link to this webinar available to members. So I'll be working with Antonia to see if we can get that available to members, which will probably maybe come through e-news or be on the website, but hopefully look out for that, guys. So thank you ever so much, everybody, for joining us tonight, and thank you so much for our northern crew tonight, hey, with Dean up near Leeds and Debbie in Scotland. You know, thanks ever so much, guys, for everything that you've provided, that information. I'm sure it's been very, very helpful, and everybody please have a good evening and stay safe.
Thank you.
Thank you.